Hello, my name is Brianna Williamson. I'm one of the psychiatry residents at University of Arizona, and I'd like to present to you today Psychosis is a presenting symptom in anti-NMDA receptor encephalitis, the complexities in reaching the correct diagnosis, and including language discordant families in care. I have no disclosures, so without further ado, let's get started. For sake of time, I'll run through this background relatively quickly, but the slides are here to fill you in if there's anything that needs further information. As many of us know, anti-NMDA receptor encephalitis, it's an autoimmune disorder against the NMDA receptors in the brain. It generally progresses quickly, starting with a psychosis, memory deficits, or seizures, and progresses to extreme autonomic instability and breathing instability. Usually these patients require an ICU admission. About 80% demonstrate dyskinesias. And though rare in the literature, there are cases with only psychiatric manifestations. About half of patients have specific MRI findings that you can see there. And an essential part of the workup is looking for a tumor, because a concurrent tumor, if removed and used alongside immunotherapy, can expedite recovery and reduce likelihood of relapses. Initially, ovarian teratoma was the tumor strongly correlated with anti-NMDA receptor encephalitis, but now it's associated with multiple more organ types and tumors. The two groups of patients least likely to have a concurrent tumor are adult men and any individual under the age of 14. The key to this diagnosis is an evaluation of the CSF, which demonstrates inflammatory changes. The most excellent markers are those antibodies directed against the cell surface antigens. These are specifically NMDA receptor and LGI1. Very important that we're keeping this on our differential because a large majority, 75% of cases, respond successfully to treatment. Treatment focuses on removal of any tumor, like we discussed before, and concurrent immunotherapy. This can take the form of IVIG, corticosteroids, or plasmapheresis. There are refractory cases that also respond to cyclophosphamide and rituximab. If we think about anti-NMDA receptor encephalitis as a non-viral encephalitis, it is the most common single form of non-viral encephalitis and affects thousands of people a year. What we also need to consider is special consideration for patients who are non-English speaking. We know that literature demonstrates a dissatisfaction among Spanish-speaking patients in relation to decision-making by providers and getting their question answered in multiple settings of medicine, including the neurologic ICU. There's also literature to demonstrate that the patients with non-English speaking mothers have worse healthcare outcomes. This specific study referenced here is in the neonatal ICU. So with that background in mind, let's jump into our specific case. Mr. M is a 38-year-old male with no formal psychiatric history. He has no past or present illicit substance use, and he presented to the emergency department with acute onset altered mental status, which include auditory and visual hallucinations and extreme paranoia. In terms of medical history, this was notable for recurrent and currently asymptomatic optic neuritis and migraines. No history of recent head trauma. His family was monolingual Spanish speakers, and this made obtaining comprehensive collateral information challenging. Psychiatry was consulted overnight for evaluation in the ED of auditory and visual hallucinations. Prior records demonstrated that he had an inpatient treatment for his optic neuritis in 2019, and he was treated with high-dose steroids. Labs on admission demonstrated a neutrophilic predominance of his leukocytosis. He had a urinalysis which demonstrated over 50 WBCs per high-power field and large leukocyte esterase. His UDS was negative. An MRI was done which showed the findings you see here, non-specific findings, but no acute hydrocephalus or obstructing lesion. There was a documented explanation of the importance of a lumbar puncture to assist in diagnosis that was completed by neurology. Per neurology note, the family refused the procedure due to concern about invasiveness. There was no documentation about interpretation services used at this visit. Neurology noted no further workup or conversations with the family were warranted, and there was significant pressure for psychiatry to admit to the inpatient psychiatry unit. Pertinent positives of the MSE were dysarthria, delusional and disorganized thought content, active auditory and visual hallucinations, and patient was alert and oriented to self only. His auditory and visual hallucinations included seeing and hearing dead people. Patient spoke English and Spanish. Family, as said before, were monolingual Spanish speakers. Patient demonstrated intermittent decorticate-like posturing with left hand over sternum. This is not noted in the neurology note, so may have been a new manifestation when evaluated by psychiatry. This was the initial differential diagnosis. Despite strong pressure to admit to the inpatient psychiatry unit, there was strong concern for an infectious etiology, either neurologically or urinary, of this presentation. And patient was eventually admitted to internal medicine for acute encephalopathy, leukocytosis, and a concern for delirium. Shortly thereafter, he received an EEG, which demonstrated, as you see there, those slow waves, and patient was loaded with Depakote. However, within hours, he demonstrated seizure-like activity and was seizing despite lorazepam and lacosamide administration. His symptoms at this time were consistent with status epilepticus. He was transferred to a different campus for continuous EEG monitoring and headed to the neurologic ICU. Of note, his lactate was 5.2 at time of transfer. He was admitted to the neurologic ICU, and you can see quickly decompensated, GCS ranging between 12 and 8. He was still having these persistent hallucinations. At one point, he rose from bed to run away from what he thought was a bomb and fell face forward. Luckily, STAT CT head demonstrated no concern for hemorrhages, and thereafter he required a 1-to-1 center and intermittent restraints. His hospital course was unfortunately very complicated. It was a 68-day hospital course. He required intubation at one point due to concurrent infections. He had an ID consult. The LP eventually came back demonstrating anti-NMDA receptor encephalitis, and he was treated at that time with IVIG and methylprednisone. He eventually also received rituximab and cyclophosphamide. And you can see there the antibiotics required for gram-negative rods that were seen on the sputum culture. I won't go into all of the information here, but important to note that he actually left AMA to home after extensive discussion with the family. There was a lot of miscommunication between family, and despite multiple family meetings, the strong sense of dissatisfaction meant that patient was taken instead home when the recommendation was to a long-term care facility. Although IVIG was continued upon discharge home, he continued to demonstrate psychiatric symptoms even 1 month post-discharge, and was following up with neurology at time that this poster and presentation was written. Of note, he did self-discontinue the Depakote and gabapentin. He felt that he was improving without them, and there was a strong sense of distrust from the family about all medical intervention at that point. So let's jump in briefly to the discussion. For sake of time, I'll be brief here, but I indicate here things that may be helpful indicators to consider an atypical cause of psychosis, one of these causes being anti-NMDA receptor encephalitis. Abrupt onset of psychosis can be a good clue-in factor, a lack of personal or family history of psychiatric illness, and of course a viral prodrome can be good indications that there might be something else going on. It's important to note that neural imaging is often inconclusive, and lumbar puncture is absolutely essential for diagnosis in most cases. Of course, important to think about ongoing capacity assessments if patient demonstrates psychosis or other psychiatric symptoms that may interfere with patient's capacity. This may be one of the most important takeaways of the case, is how often red herrings are misattributed to psychiatric symptomatology. We spoke before that 80% of cases have dyskinesias, and this is a really helpful signal that we should consider anti-NMDA receptor encephalitis. However, often patients have already received an antipsychotic medication, perhaps for behaviors or hallucinations, and often these dyskinesias are misinterpreted for tardive dyskinesia, attributed to the antipsychotic instead of the underlying cause. And as we talked about before, autonomic instability is a core feature of anti-NMDA receptor encephalitis. And so sometimes we see things like rigidity, elevated CK, rhabdomyolysis, hypothermia, and sometimes this is falsely attributed to NMS. So when the symptoms aren't really adding up, it's important to reconsider our diagnosis at baseline. I would be doing this case a sincere injustice if I didn't speak just briefly to the clear mistrust that the family had of the medical system throughout his complicated hospital course. Many things likely contributed, but I believe language and cultural barriers were huge parts of this mistrust, and they contributed to a delay of diagnosis and a suboptimal discharge plan for the patient. Unfortunately, this case is aligned with many reports that Spanish-speaking families have worse healthcare outcomes, less patient-centered care, suboptimal communications with providers, and markedly lower satisfaction with care than English-speaking Caucasian patients. Something really worth keeping in mind, and the importance of reliable interpretation when we're working with non-English-speaking families. So to tie this all together, anti-NMDA receptor encephalitis is a life-threatening condition. It's more common than most doctors realize. It can present with only psychiatric symptoms, and as we've spoken before, there's an immediate need for treatment because its severity requires ICU admission often. For this reason, we should maintain a really high suspicion and a low threshold for an LP to establish this diagnosis. Of course, dramatic behavior changes can frighten family members, especially families without adequate context and health literacy. For these reasons, it's absolutely crucial to prioritize reliable interpretation, adequate time, and even more frequent communication with non-English speaking families in their primary language. This is even more essential when the family has concerns about critical aspects of the diagnostic workup that can alter medical care outcomes, in this case, the lumbar puncture that was necessary for diagnosis. Given the possibility of ongoing sequelae of disease, continued trust building carries implications in long-term health outcomes and continued engagement in care. Thank you for sticking with me through my presentation. Here are my references. I look forward to answering your questions.